Great presentation. My good friend Professor Ramandeep is next. Ramandeep is a great surgeon, and he is instrumental in, along with Dr. Vishali, in the great work that they are doing in Advanced PGI Center in Chandigarh. And Dr. Ramandeep is going to speak on chorioretinal biopsy. Over to Ramandeep.
Biopsies, and if you this is not a very extensively done procedure, but one should know that when do we do it. So indications are when we are trying to decide whether it's a infective etiology or a immunological etiology, where you need some kind of a biopsy there. And if you are treating an infection extensively and it is not getting treated, you want to exactly know what is this thing. So you want to take chorioretinal biopsies, and if you don't have any cells in the aqueous or in the vitreous, so they are not going to help you. So help has to come directly from the tissue if the retina and choroid are involved. And now the latest is people have added that in case of small melanomas or large melanomas, where they are treating these patients with without enucleation, they are trying to take tissue from every sample of melanoma, because it helps in the prognostication, because there are various gene expressibility proteins are there which will tell you that prognosis of a melanoma patient. So that has become another indication. So this is the gist, this is the chart which is very important, that the chorioretinal biopsy can be done ab externo, or it can be done through intravitreal route, ab interno. So I'll start with the transscleral route. So either you can go, kind of a FNAC. We used to learn that, fine needle aspiration biopsy, like what the surgeons do, and directly impale the lesion. And this is characteristically done for the lesions which are anterior to the equator. And so the external route is for anterior to the equator, and it can be done FNEB, or a transscleral biopsy can be done. Like in this case, a transscleral biopsy has been done, and you will see that we do a partial thickness scleral flap in this patient, and then under that partial thickness scleral flap, the full thickness of the sclera and the part of the choroid we are interested in is taken out. And why it is important to leave this partial thickness, we can suture the globe, and in case it turn out to be a malignant lesion, you can put a plaque over this lesion. That is very important. And if it is a malignant lesion, your malignant cells will be sequestrated within the sclera, so it will not come out into the conjunctiva. And of course, we are using the precautions like distilled waters in these patients. And similarly, in a FNAB also, people use raise a scleral flap and then enter through the sclera. And then, of course, from where they have entered the needle, they just cryo that site. So this happens this is useful for the anterior lesions. And this was done in this patient, and we were suspecting between a tubercular lesion or a melanoma. Classically, it was not fitting into a melanoma. Patient had a history of TB there. It turned out to be a tubercular lesion than a malignant lesion.
There's a filter paper you are using, no?
Sorry, sir?
In your sample,
Yeah.
print out a filter paper.
Yeah, we'll take it on a filter paper, and then we have to put it in the the special media there, and then send to the histopathology. That has to or it will just send in the formalin actually. So the next method is transvitreal. So if you have a lesion which is posterior to the equator, that is amenable to the your vitreous cutters, and those cases you go transvitreal. So if you in the transvitreal also, there are approaches like, if you see this, whether you want a full thickness retina or a full thickness choroid or not. If you don't want that, you can do a transvitreal fine needle aspiration biopsy, or you can do a biopsy using a simple 25G or 27 cutter. And that biopsy can also be without PPV and no PPV. I'll tell you how it is done actually. So this was a 27G vitreous biopsy without pars plana vitrectomy. This was propagated by Dr. Mrityunjay from San Francisco. So this technique I have used in few patients, So we don't do full vitrectomy there. We use 27G trocar cannulas. We use our bolt cannula, and directly we impale the 27G cannula into the lesion actually. So once you impale, absolutely just like a needle. You don't need a needle. You just go inside and impale it, and then you switch on the cutter with a low cut rate, and because you will get a sample there. No infusion, no need of infusion also. You just because you made these ports to see your endolight where you're going. So because it is not done with the indirect ophthalmoscope, but yes, there was a group who was doing it with the indirect ophthalmoscope also, but that was a fine needle aspiration biopsy. This is a more controlled procedure because you're using 27D trocar cannula and you just impaling into the lesion and taking the biopsy, and while coming out you are not cutting, because that moment you'll cut the retina. You're not supposed to cut the retina. If it bleeds, so just increase the bottle height, because there the role of infusion, sometimes people put infusion to increase the bottle height. So I two cases I used air instead of this thing. The fluid there. I'll tell you why. Because air also, you can raise the pressure and the air bubble will go inside. It will not. You will not ending up putting the fluid inside the eye.
You operate the cutter.
Yeah.
While inside the lesion.
Inside the lesion. You inside the lesion. Take the sample and then take it out. You don't have to. You don't have to laser the lesion. You just leave the eye like that.
In the sample.
Yes.
Then you can use your infusion pressure or air, because
Absolutely.
No fear of dilution.
Absolutely. And the only thing which has to take care, you have to cryo the ports you have made in these lesions if you are suspecting a melanoma lesion. So second is now with PPB. So if you have a lesion which is less than 3 millimeter, where you know that it's more like it's not a solid lesion like lymphoma. It's more of a solid lesion like melanoma. It's more of a lymphoma lesion which is masquerading as uveitis. There you use the PPV method. So here is the video of this, how this is done. So again, to emphasize, because we want to take the samples of the vitreous which is undiluted. We don't infuse the infusion cannula with the fluid there. We straight away start with the air. So we will take the undiluted vitreous samples and do the vitrectomy under air. And this is done with a low cut rate so that you don't destroy the cells there. Approximately 2.5 to 3 cc of vitreous can be taken under the air, and you don't have to just have to do it slowly. And you take samples from the anterior vitreous, mid vitreous, and the posterior vitreous, and label it and send it that way to the person who is. This is vitreous biopsy. This is vitreous biopsy. And after you have completed the vitreous biopsy and the vitrectomy, then if you want to take a subretinal biopsy, to see with the laser, I've made a retinotomy there. Now with the aspiration tip, now I have taken a sample there. So this is how you take a subretinal fluid, and this is the kind of a needle is being used. So if you are using a 25G cannula, you don't have to, you have to laser it and leave the eye under air. And of course, you have to complete the vitrectomy and remove the hyaloid before you take the sample. And sometimes you have to put the gas in these eyes also.
You think that soft tip cannula that is sufficient, or you have to sometimes?
I think it is more than sufficient, sir, with the soft tip cannula, because you are making in the area of the lesion there. You can take it with the 25G cannula.
Sometimes people also use bimanually forceps and scissors.
No, so that is for the full thickness. So this is for the subretinal fluid only, where you are planning to take a subretinal fluid, which is.
What is the indication of full thickness?
In the full thickness indication will come where this procedure fails, or you are directly involvement of retina is there or the choroid is there. In this case, we know that lymphoma cells are in the subretinal space. There is no need to take that. So if the biopsy fails in this case, then I will take that. Otherwise, subretinal fluid is sufficient in these patients. And sometimes even I have used now a controlled active aspiration using a 39G cannula, also using a vitreous fluid extractor to take the samples in these patients, because that is a better controlled procedure and you don't have to laser it sometimes also. For the cytology. And of course, this is another video where it's just a use of microscopic the integrated OCT has been shown, that how the OCT shows that how the with the aspiration the cells are literally moving into the your silicon tip cannula. It shows that yes, you have taken sample from the right place, but it is not required in all the patients. Just to show you that how OCT will tell you that you have taken a sample, an adequate sample has come for the cytology in these patients. Yeah. So this is the indigenous thing you have to make, so that your assistant will aspirate while you are doing the cutting there, and the cutter, the aspiration tip is put to the 2 cc syringe. Yeah, absolutely the same way it has been done. And of course, once you have taken the samples, before taking the samples, you should know that where all they will be going. So they should be labeled and put in the ice box if you're taking the cytology samples, and then sent to the person concerned, because he is the most important once you have taken the samples. They are not present in the OR, they are just less than a kilometer away, sir. So that is the advantage of being in a center. So that is the first thing. If you are planning to take these retinochoroidal biopsy, you have to have a person who is going to look at these friendly to you, nearby you, and you should be ready with the media and wherever you want to send. So if you are not, if you don't have this kind of a teamwork, please don't do these procedures. So next is, as you have said, sir, where to take full thickness biopsy. So if you have a uveitis infiltrating lesion, if you have a retinocoroid, both is involved, and if you have a tumor less than 3 millimeter of the biopsy have failed now there you will take a full thickness lesion. So this is a patient where we have, somebody has given Ozurdex also in an infectious patient, but despite everything, we were not able to control the infection. So this patient actually landed up with vitreous hemorrhage and a subhyaloid bleed there. So we took him for surgery because of the vitreous hemorrhage and bleed. And we thought we might be able to take the biopsy now, since the bleed, we are already going into the vitreous cavity. So you see this patient, after clearing the vitreous hemorrhage, the subhyaloid bleed was cleared after making a small hole in the hyaloid there, and you will see that there was a lot of blood there, and eventually we were able to see the retina. So this is where we plan to take a retinocoroidal biopsy. A demarcating laser is done. We always take the normal retina also and the diseased retina also. This helps the histopathologist to see it actually. So we need to do a hybrid kind of a thing, because the vertical scissor comes in the 20G, and we make a fourth port and then go inside, like Dr. Sangeet has done the 100% diathermy. Now we will be cutting the retina and the choroid both. So if you want retina, you can take retina only, but if you want retinocoroidal biopsy, you can take both, and you will be seeing some bleeding, but the bottle height can be raised. Eventually, retina and the choroid both will separate from each other, so you can take them out, one piece after the other. So this is how you see the bare sclera there, and some bleeders are there. Now we have held the choroid there, and we'll take it out with the
Ramandeep, in this case, you decided retina and choroid biopsy.
Absolutely, it's a retina and choroid biopsy.
Indication?
Because it was a retinocoroidal lesion. It was a retinocoroidal region. So this was that was the choroid. Now this is a retina coming there. So this is how you take a retinocoroidal biopsy, and then after doing a fluid gas exchange, because this was a superior thing, so you can put
what forceps you used?
This was the vertical scissor, sir.
Scissors, but to pull it out, what did you use?
Sorry,
to pull it out.
Grasping, sir.
End grasping.
I don't want to use ILM because it will,
that's the point I wanted to
traumatize it. End grasping is always better.
That's what I wanted. Yes.
So this is how the patient looks like after the surgery, and eventually we were able to show the toxoplasma in this patient actually. So once you do CRBs, I think the diagnostic the rate range is 55 to 100%. Good labs will have 100% results. And again, I've told you the importance of the teamwork here. and who will assess the sample, and who will take care of all these patients. And complications do occur when you do these procedures, but they can be taken care.
So fantastic, President Ramandeep. Just one small query. You emphasize. Would you highlight? Of course, at the end we'll ask the questions.
Yeah.
But just one small one. What is the use of ultra wide field? Now that we have access to ultra wide field imaging modalities, multimodal. So, what is the role of there in assessing the preoperative biopsy site, assessing with the cytopathologists at that stage, the site of biopsy, how to choose the biopsy site? Please throw some light.
Ultra wide is not going to be effective. Really going to help in these situations. But yes, in uveitis we use ultra wide angiography and the ultra wide, the fundus photography a lot. So that is a different thing. But here, I think is just a better documentation is more important.
And lastly, you showed toxoplasma was the outcome.
Yes, sir.
So after that, in the postoperative period, siliconoid field dyes, the effect of oral toxoplasma drugs, could you compare that to? Just a sidelight.
No, it's a very important question, because we do nowadays in uveitis we do a lot of vitrectomies there. So this is a this is a misconception that once you have a vitrectomized the eye, the anti-VEGFs or antibiotics or the Ozurdex injection is not going to work, or they will quickly be absorbed. But this is not true. So
the oral anti-toxoplasma drugs,
oral,
also
everything, the availability is good.
Absolutely.
All you have to take care is once a silicone oil is there, you have to decrease the dose if you're giving it intravitreally. But
what is your current indication for chorioretinal biopsy? Like, is it the infective and malignancy part, or anything else?
Sorry, sir.
What is your indication for chorioretinal biopsy? Is it the infective and malignancy?
It's infective and masquerading, obviously malignancy.
Yes.
These are the two indications which are there.
Okay. Any other indication?
Other than, sir, the indications comes that now the people are doing for the melanoma. For prognostication of the melanoma. Melanoma, I know that this patient requires a plaque therapy. But in West nowadays, before doing a plaque, they will take a sample just to prognosticate the patient, because nowadays first the gene expressibility factor is there, and then the targeted therapy is there. If patient falls in that, then they will give plaque therapy also and targeted molecule also.
Okay.
Great. Thank you so much, Ramandeep.
Thank you.
We'll have all the other questions at the end. My honor to again invite Sangeet Mittal.
Unfortunately, there. So this is a this is a misconception that once you have a vitrectomized the eye, the anti-VEGFs or antibiotics or the Ozurdex injection is not going to work, or they will quickly be absorbed. But this is not true. So
the oral anti-toxoplasma drugs,
also everything, the availability is good.
Absolutely.
All you have to take care is once a silicone oil is there, you have to decrease the dose if you're giving it intravitreally.
But what is your current indication for chorioretinal biopsy? Like, is it the infective and malignancy part, or anything else?
Sorry, sir.
What is your indication for chorioretinal biopsy? Is it the infective and malignancy?
It's infective and masquerading, obviously malignancy.
Yes.
These are the two indications which are there.
Okay. Any other indication?
Other than, sir, the indications comes that now the people are doing for the melanoma. For prognostication of the melanoma. Melanoma, I know that this patient requires a plaque therapy. But in West nowadays, before doing a plaque, they will take a sample just to prognosticate the patient, because nowadays first the gene expressibility factor is there, and then the targeted therapy is there. If patient falls in that, then they will give plaque therapy also and targeted molecule also.
Okay.
Great. Thank you so much, Ramandeep.